Okay, thank you very much for joining us today for this webinar. My name is José María Chema Valderas. I'm the chairman of the Working Party in Quality and Safety. And I would like to welcome you to this second webinar in the webinar series on the occasion of the release of the OECD PaRIS report. We had already a previous webinar, a rather successful one by Candan Kendir from the OECD and also a family physician and member of WONCA, in which she introduced the main results of the OECD survey. You don't have to worry, because we will also take you briefly through some details of the scope of this. And it is my pleasure to be hosting this webinar that we're very lucky, because one of the things that we saw in the report is that there were two countries that were performing particularly well and in terms of the primary care performance. And we are very lucky to have the leading partners, family physicians, responsible for that work in their own countries. So I would like to introduce the two of them. So we have Zalika Klemenc Ketiš. She's a family medicine physician employed at the Ljubljana Community Healthcare Center, where she also leads the Institute for Research and Development of Primary Care. She's a full professor of family medicine at the medical faculty of the University of Maribor, where she's the head of department of family medicine. She was the president of the European Association for Quality and Safety in Family Medicine, EQUIP. She's a member of the executive board of the European Association of Family Physicians, WONCA Europe, currently acting as honorary treasurer. And she's an international expert in the field of family medicine and quality of work, and an active researcher, mainly in the fields of quality and safety in family medicine, education, and new technologies. We also have with us Bohumil Seifert. He's a teacher and a researcher at the Institute of General Practice at the First Faculty of Medicine of Charles University, which he led until 2023. In the Czech Society of General Practice, he's a scientific secretary and represents it in WONCA councils. He's still working part-time in general practice. His doctoral thesis and habilitation thesis were devoted to epidemiological studies in gastroenterology, and he's one of the leaders of the National Screening Program from colorectal cancer in the Czech Republic. For years, he was a member of the steering committee of ESBCG, the WONCA Special Interest Group. In addition to publications in Czech, including a series of textbooks, he has 45 impact international papers in his bibliography. He was a member of EQUIP and participated in several projects in the field of primary care quality. He was the national leader of QualiCop study, which was a primary care study on the performance of primary care using the structure, process, and outcome framework led by NIVO. And he's also the national project manager of the PaRIS study in the Czech Republic. So thank you very much for presenting your work with us today. And without further ado, please over to you, Zalika and Bohumil.
Thank you very much for that kind introduction. Hello also from my side. Me and my colleague Bohumil will today present some of the results from PaRIS study, focusing mainly on Slovenia and Czech Republic. You might wonder why we chose these two countries. Well, the first reason is that both countries performed quite well, which was seen from the results of the PaRIS study. And on the other hand, these two countries don't spend so much money on primary care. And that was the main reason we wanted to prepare this webinar, and the other reasons you will learn through the presentation. Okay. So we will start with the presentation of both healthcare systems, just to give you an insight what is the background for the results of the Paris study we will show. So first, something about Slovenian healthcare and primary care. We have a gatekeeping system, and we have primary care teams which are multi-professional. Not only family doctor is there, but also nurses, community care nurses, and other professionals like clinical pharmacists, physiotherapists, social worker, and so on. A primary care is not only focused on acute problems, but also on chronic conditions and preventive care, which is integrated into primary care services. Our healthcare system is mostly public. We have around 60 community health centers where around 70% of family physicians are employed, and 30% family physicians are private, but they have a contract with the insurance company. Healthcare centers work mainly to provide integrated care, not only family medicine, but also pediatricians, dental services, gynecologists, and emergency services. Our citizens must register with a family physician, and family physicians receive payment mainly based on capitation. This was changed several months ago, and additional services are reimbursed separately. We have only one insurance institute. This is the National Insurance Institute of Slovenia, which funds the primary care and also other level of primary care. So this is the public health system. I would now ask Bohumil to present the Czech healthcare system.
Thank you, Zalika. Thank you, Chair, for introduction, and good afternoon to all from Prague. And allow me to give you a brief overview of healthcare and primary care in the Czech Republic. The system is financed through public health insurance, and primary care providers throughout the country are independent contractors of health companies, health insurance companies. We have a stable network of general practitioners' offices that has been developing for almost 50 years. Specialized training is a prerequisite for opening and managing a practice. The majority of practices are still single-handed, but current and supported trend is the creation of team practices. Although Czech Republic doesn't have a strict gatekeeping system, 9 out of 10 patients do seek care through their GPs. We run a list system, and people quite strongly adhere to primary care providers. And registration with GPs opens to patient the gate to systematic prevention and screening, to chronic care coordination, guidance through the healthcare system, and rational use of specialists. Thank you.
Thank you very much. I will now briefly introduce PaRIS study because several days ago there has been already one webinar. But anyway, so that you know what we are presenting. So PaRIS study is the patient-reported indicator survey. It was the global initiative by OECD. And it is the first study ever that aims to measure patients' experiences and outcomes of primary care through patients' eyes. And PaRIS especially focused on chronic conditions. So we wanted to measure what matters to patients. So their quality of life, daily functioning, how they feel about the care they receive. We included patients age 45 or more, and they answered questions about their health and daily life and experiences with care, like communication, trust, access. And we also had a different questionnaire for doctors or for primary care practices. So then we were able to compare both data. Why we did this study? We wanted to better understand patient needs and expectations. We wanted to get feedback that can help improve patient satisfaction and outcomes. And we also wanted to get the insight how the practices support good care. Why this matters? Why the results of PaRIS matter? Because we gave a voice to patients. This is not many studies did this, but our PaRIS study focused mainly on patient experiences. We didn't only focus on clinical indicators, but also on non-clinical indicators such as emotional well-being, general health, and so on. PaRIS results support and help identify strengths and gaps in primary care in participating countries. It promotes quality improvement, and also it enables international benchmarking because we use quite rigorous methodology and the same questionnaires everywhere. The questionnaires were tested and validated through very rigorous process. Within PaRIS, we focused on 10 main indicators. 5 of them were patient-reported outcomes, and 5 of them were patient-reported experiences. The outcomes we measured was physical health. It was the ability to carry out everyday physical activities, then mental health, perceptions of quality of life, mood, ability, and so on, with social activities and so on, social functioning, so the extent to which a person can carry out their usual social roles. Then we measured the well-being of the patients and also general health, like an overall measure of how they feel in general. Then we had 5 patient-reported experience measures. We measured confidence to self-manage, so how confident patients feel that they can manage their own health. We managed care coordination through patients' eyes, so what experiences they have with seamless care coordination. Then we measured person-centered care, the extent to which primary care is focused on person's health needs. Then we measured quality of care seen through the eyes of the patients, and then we measured trust in healthcare system. This was not focused only in primary care, but on healthcare system as a whole. So this was the short introduction of PaRIS. And now I ask again my colleague Bohumil to present key results from Czech Republic.
Thank you again. Thank you for having the opportunity to share the PaRIS results of Czechia. Overall, we evaluate the participation in the PaRIS survey very positively, and as you will see, also the results were favorable for us in many ways. This graph shows the burden that chronic disease represents for the current general practice in Czechia and similarly in the other countries. The population is aging and the number of chronically ill people is increasing. In the Czechia, among patients of general practitioners aged 45 years and older, 85% have at least one, and more than 53% have 2 or more chronic diseases. In another graph, yes, this is the spider graph that on country scores on 20 indicators, 5 PROMs and 5 PREMs, as Zalika mentioned, that was presented at the launch of the PaRIS project in Lisbon this February. The dark blue shows the highest OECD results, and the light blue, the lowest OECD result, and the orange in the middle represent the OECD average. Can I have the next one? In this graph, you see how countries compare on the PaRIS 10 key indicators, and you can see that Czechia is among the countries that show indicators above the OECD average or in the area within the OECD average. In 3 indicators, dark blue, we are approaching even the best OECD countries in the survey. 1 prom, the social functioning of chronically ill people, and 2 prems, particularly how good the experience of chronically ill people is with the care provided in general practices, and how patients rate patient-centered care of general practitioners. Can I have the next one? This is another general finding from the PaRIS project, which indicate how chronic diseases affect social life. Each additional chronic condition deteriorates social life and fulfilling of social roles like at home, at work, in the community, and responsibilities as a parent, child, spouse, employee, friend, etc. And also in this parameter, the Czech Republic, similarly to Slovenia, shows favorable results in comparison with the OECD participating countries in people with 1, 2, or 3, or even more chronic conditions compared to the other OECD countries. Thank you. This is another general finding from the PaRIS project, indicating that the length of the relationship with the same primary care professional affects the trust of a patient. Longer relationship means bigger trust, but also experience of quality care. If you go to the other slide, the other slide shows that Czechia excels in this discipline in the length of relationship with the same primary care provider at 5 years, and similarly in 10 years. 75% of patients from the Czech Republic in PaRIS survey report that their relationship with their GP lasts more than 5 years, while in more than half of the countries, less than 60% of people have been with the same professional for more than 5 years. Yes. Now I pass again to Zalika.
Thank you. So a few results from Slovenia. This is quite similar to what has already been shown by Bohumil. This graph indicates that chronic patients burden and also multimorbidity burden in Slovenia is also high. So this proves that PaRIS focused on the right population, and also that PaRIS results will give us the opportunity to address issues connected with chronic care, which is becoming the core business of primary care. This is also this similar graph on 10 indicators, but it presents the results of Slovenia. This blue line are the results of Slovenia, and this is the lowest and highest average of OECD countries. You can see that Slovenia is doing quite well regarding patient-reported outcomes. And there is some room for improvement on the side of patient-reported experiences, mainly on confidence to self-manage. This has been shown also by previous studies in Slovenia, indicating that we need to focus more on empowering patients to perform self-care better. There is also some room for improvement in the coordination of care. And here, oops, sorry. Here you can see the graph which is comparing the results on 10 indicators of Slovenia and OECD average. I can say that Slovenia is one of the most average performing countries in PaRIS study, because all the levels of indicators are slightly above or slightly below OECD average, which indicates that our country is performing well in comparison to other countries. Now I will focus on the results of Slovenia versus Czechia. Bohumil, I forgot, is this your part or mine?
Yes, I can take the
Okay.
comparison of the
Okay.
two countries. I'm happy to
Okay.
do it. And I start
Thank
again with
you.
spider graph. If you see on this spider chart, you can see similar shape and remarkably similar level of key indicators in both countries without significant differences. Both countries receive good ratings from patients, especially in PROMs on the right side, as Zalika mentioned, social functioning, especially mental health, and also in PREMS with an excellent rating of experience of quality provided by primary care. In the Czech Republic, patient rate the coordination role of practitioners slightly better, while a high trust is seen in Slovenia. By the way, the overall trust in the healthcare system was one of the poorly rated indicators across all OECD countries participating. Yeah. Next one, please. Can we have, yes, this
Yes.
when we go more in details to the indicators, so and talking about PROM, so physical health reported by patient, that both countries perform above the OECD average, with Slovenia slightly ahead, suggesting better self-reported physical health among people with chronic conditions. In mental health, Czechia performed best here, indicating strong perceived mental health. In chronic patient social functioning, both countries excel in this indicator. They have identical scores. They show that chronic conditions have a lower impact on a daily life. In well-being, equal and above average rating, suggesting comparable and positive life satisfaction. And in general health, slightly below average, both countries show some gap in perceived overall health. And when we look at the PREMS, so Czechia stands out in confidence to self-manage, reflecting stronger patient empowerment and chronic care support, and excel again in experience, quality of care provided by GPs, notably lead suggesting higher satisfaction with the care received. In opposite, trust in healthcare system is better in Slovenia, which aligns with the average, while Czechia lags behind, indicating trust disparities, which I'm not able to explain. And in experience coordination, Czechia performs better, implying stronger care integration and system navigation. And in person-centered care, Czechia scores higher than the OECD and higher than Slovenia, pointing to potential communication or personalization gaps in Slovenia, which we discussed. So, and this is another graph. Look at the comparison of experience, quality of care and health spending. This is very interesting graph. If you look at the horizontal level, 1 and up, that positive with the care experience, care provided increase, and from vertical level 1 to right, health spending increases. It can be said that the countries in the left upper quadrant, like Slovenia, Czech Republic, Saudi Arabia, effectively allocate resources for care in terms of patient ratings. This graph suggests that rather total spending effective allocation is more important from the patient perspective. Or in other words, the money spent on primary care in our countries are spent efficiently, which is very good. And you see that, for example, Switzerland spends twice more and United States even 3 times more. So we can conclude that there are important and positive similarities in both countries. Patients report above average social functioning and well-being in both countries. It shows that we help patients maintain daily function and satisfaction despite chronic illness. Patients report strong physical and mental health, which indicates effective chronic disease management strategies. And in both countries, patients with chronic diseases have a longer-term relationship with their GP than the average in OECD countries. Not everything is optimal. Both countries need to improve e-health and especially health record sharing. And we found also some differences in care coordination. Czechia here scores higher, reflecting more efficient provider collaboration. It's, by the way, for us very important feedback because specialist care is quite fragmented. System tends to offer specialists for every disease, so the need for coordination role of GP has never been greater, and for patient-centered care as well. In trust in the system, Czechia trails Slovenia by 9 points, possibly reflecting systemic or historical differences in perception. And Czechia performs significantly better in experience, quality, and self-management, possibly due to stronger structures for patient empowerment and quality assurance. So that's, I think, all from my side. Thank you.
Yes, thank you. If we try to interpret these similarities and differences, Czechia excels in most care experiences and patient empowerment indicators, which suggest more responsive, coordinated, and satisfying healthcare system. Though it faces a trust gap, but as already said, trust was scored low, the lowest indicator in all OECD countries. Slovenia performs well, especially in physical health and also trust, but we have problems in self-care and also in coordination. Both countries exceed OECD averages in many key areas, but improvement is in the areas of general health perspective and specific system coordination elements is still needed. I would like now to present to you some implications of these results from Slovenia and Czechia for the international primary care community. I would like to show you 6 key messages that stem from our results. The first key message is that we should focus on value, not just spending, because we saw that we can provide higher value care with moderate financial resources, and probably that primary care system can be reorganized to be more efficient. This is not a new key message, but again, it is very important, and it was also shown through PaRIS results that we have to strengthen primary care because it is the backbone of the system. For example, one result of the PaRIS showed that if the trust to primary care is higher, then also the trust to healthcare as a whole is also higher. Then we need to empower patients to manage their own health. This is especially important nowadays, where there is a lack of workforce, not only physicians, but also nurses and other healthcare workers. And we need to educate patients to be able to take care for themselves more efficient, and hence maybe lower the burden on the healthcare system. PaRIS also showed that person-centered care is key. I think this is one of the rare studies that actually measured person-centered care. It is one of the values of family medicine, but it is quite difficult to measure, but PaRIS did it. So we can now say, based on the data, that person-centered care should be the norm of primary care. We should invest in building public trust to healthcare and to primary care. And another very important message from PaRIS is that we need to use patient-reported measures to improve care. We now have validated tools that can measure patient-reported experience and outcomes, and this is only a start of our assessment of value-based care, and we should continue with measuring it. What have we gained from the PaRIS survey? I mean, what Slovenia and Czechia gained, and also international community. So we assessed healthcare system from the patient's perspective. It is very important because before this study, we mainly focused on measuring clinical indicators. And it is also equally important, or even more important, to assess how patients are feeling. Is primary care giving them the things they need, and so on. And we also, with PaRIS, I think we raised recognition of primary care in all countries. We also raised the recognition that we need to take care of our chronic patients, because they are the majority of our patients. We recognize that in general, patients assess primary care as positive. It is very important, like Bohumil said, that our countries exceeds other OECD countries in continuity of care. This is also one value of family medicine that directly affects patient outcomes, and also the life expectancy. And the other information is also that we can spend money on primary healthcare effectively without taking the chance to lower quality of care. And of course, the data showed us on which areas in both countries we need to focus more. I would like to tell you now some take-home messages me and Bohumil would like for you to remember from this presentation. Slovenia and Czechia are leading examples of how primary care systems can achieve excellent patient experiences and outcomes despite moderate economic resources. The key success factors of both countries include strong family medicine, patient-centered care, self-management support, and system efficiency. We think that these lessons that can be learned from the two countries are highly relevant and also transferable across diverse health systems in the world, regardless of their GDP or spending levels for health care. I'm sure that we will have some questions, but when we were preparing this presentation, we were also thinking about what are the things we need to discuss, or it is worth discussing about. maybe what is the value of Paris for WONCA community, then how do WONCA core values connect with Paris study? Because you know that we have the document on WONCA core values, but now we actually also managed to measure these core values, which is, I think, very rich results. And the last point for discussion is how to develop and support primary care using Paris results. Thank you very much. I will now stop sharing.
Thank you
and
so
give
much.
my word back to Chema.
Thank you so much, Zalika and Bohumil. Fantastic presentation, and a privilege to be hearing from you that have been coordinating activities in primary care from nationally in your countries. It's now also we're very privileged as well. We have the President-Elect of WONCA with us today. I was about to say tonight because that's how it looks through my window here in Singapore. But we have Viviana Martinez-Bianchi, President-Elect of WONCA, Associate Professor at Duke University and family physician. And Viviana also has produced expert commentary on the OECD PaRIS, and I think that she's ideally placed to start with by addressing perhaps two, if not all three, items that you were proposing for discussion, Zalika. So please, Viviana, over to you.
Hi. Sorry, I was not being allowed to unmute initially. Thank you so much, Chema, José María Valderas, Professor Valderas, Professor Klemenc Ketiš in Seifert. And I just really enjoy your presentation a lot. As President-Elect of WONCA, I want to emphasize how valuable this PaRIS survey is, not just as a data collection tool, especially because it used what matters to people, you know, the use of the questionnaire, the measure the patient's views of their health status, and the measuring the perceptions of their experience while receiving care. But to me, it's also a mirror reflecting the essence of what we strive to do in family medicine and general practice, to care for people, not just diseases, right? And the findings from both Slovenia and Czechia reaffirm a truth we have long known in family medicine and general practice, that when you strengthen primary care and build long-term trusting relationships between patients and their doctors, health outcomes improve. And that this is not this also can happen even when resources are limited. That both countries show that both countries have shown that a person-centered longitudinal model of care is not just ideal, but it's also doable. That these are systems with moderate economic resources, but excellent patient-reported experiences and outcomes. And this gives us hope and evidence to advocate for stronger family medicine in every country, not just those with high GDPs. Now, I would love to see a similar survey done with patients in low income and lower income, lower and low middle income countries as well, not just those who are moderate or high income. But there are also some takeaways I like to highlight. Number one, trust and continuity matter. As we saw, patients who have a long-term relationship with the same provider report higher quality of care, which I think it was probably some of the most important findings. And this aligns with what family doctors have observed for decades. Continuity is not just about convenience, it's about safety, it's about trust, efficiency, better outcomes, and it's also about dignity, the dignity that happens from a trusting long-term relationship where patient and doctor know each other, and the patient can trust that the primary care team is really caring of them because they know them. Another Another thing that I noticed was that chronic disease is now the norm among adults over 45, with over 85% of patients within the Czech data reporting at least one chronic disease and over half with multimorbidity. This reinforces how essential it is for systems to be equipped to manage complexity. Again, something we know in primary care, that we manage complexity often. We also need the support of systems to allow us to manage that complexity, not just through guidance, but through relationships, coaching, and coordination of care. Another thing that I see is that empowerment and person-centeredness are essential. Czechia's strength in patient empowerment reminds us that healthcare is not something done to people, it's something that we do with them, right? We work together with people. Slovenia's emphasis on physical and mental well-being show how primary care can support whole person health when it's embedded in community and prevention. I think there's also something that we need to work more on, the need for better coordination and e-health solutions. Even strong systems face challenges in care coordination, and that I think digital health holds promise, but must be implemented in ways that enhance and not replace that human relationship, but we are valuing so much. That trust comes with the human relationship, and this is why it's so important. And then patient-reported measures should be central. The PaRIS initiative, I see not just as a research tool, I see it as a compass. It helps us evaluate if we are actually delivering what matters most to patients. And I urge countries to use these results for system improvement and not just from benchmarking. In regards to the values, at WONCA, we believe strong primary care is the foundation of equitable, efficient, and compassionate health systems. And we've been advocating for decades for training, support, and recognition of family doctors and general practitioners and the teams around them. And we believe strongly that listening to patients through tools like PaRIS, we listen to patients individual, each person at a time, but tools like the ones from the PaRIS report are essential for that accountability and transformation. And then other core values of WONCA: care across the life course, continuity, coordination, comprehensiveness, compassion are all present in what we are hearing you share today. These values are not theoretical, they are practical, they are measurable, as the PaRIS data shows. So how do we move forward? We must share and learn. Thank you so much, Chema Valderas, for organizing this, and WONCA Secretariat for supporting the presentation. Thank you, Zalika and Bohumil, for doing this work. Thank you, many others who are in this meeting today, for doing this kind of work, because we must share, we must learn as we're doing now, and we must adapt to other contexts. Second, we must advocate for investment in primary care, not just in infrastructure, but in time for relationships, for shared decision-making, and for continuity. I hear as I travel around the world that some of our colleagues have 2 to 5 minutes for patient care. That doesn't allow for that development, that trusting relationship. We need to be able to allow people to have the time that is necessary to develop that relationship. And then we need to train and retain family doctors and general practitioners and primary care teams who can lead this transformation. And we must center patients' voices, people's voices, communities' voices in everything we do. And I'm going to close my remarks saying that WONCA is proud to support the work that every one of you is doing. We are proud to support the PaRIS initiative. We are proud to look forward to working with OECD and member countries, but also we want to work with countries that were not represented by this report, to continue to collect the data, translate the data into action, into better lives, especially for people with chronic conditions who depend on our care the most. Thank you, and I look forward to the future ahead.
Thank you so much, Viviana. Thanks very much, because I know that many also joining today will have, you had to find time between your patients for being able to to join us today, and we're very grateful for also to be able to appraise the WONCA, the institutional perspective on the report. We have sufficient people to have a very healthy conversation now, a discussion, and I think you have an outstanding opportunity to ask people who have already been parts of the project what was their experience, what they've learned. If you are interested in doing in your own country, that was something that came up repeatedly in the previous seminar by Jandan Kendir. That's your opportunity. So we'll start a questions and answers session now. If you please can raise your hand using the tools in Zoom, then I will be very happy to hand over. And we'll start with Andrei Ijaji. If you can please very, very briefly introduce yourself so that we know where you come from and what is your role possibly within WONCA.
All right, thank you very much. José, Andrew Ijaji, family physician from Benue State University Teaching Hospital in Makurdi. That's Benue State in Nigeria. I was there, I was present in the last webinar, and I want to thank the organizers. I mean, it's wonderful. I'm very much enlightened. I really wish that family physicians, like the Society of Family Physicians in my country, will all have been logged in and push for some policy and, you know, data backing so that we can start gathering data and have our own records from Africa, from Nigeria and Africa. It would be really good. So, but I want to ask a question. I want to know why Slovenia and is it Czechia? Why these two countries? Is it that they have a very good record of primary health care? Were they chosen ahead of time to do this study? I mean, and then gather data. So, or is it that the health system is so well established that you can easily get out this data that we have listened to today? So I really wanted to know, have an idea so that maybe it can be a learning point for some of us from other countries. Thank you.
Thank you, Andrew. Either of you, Zalika or Bohumil?
Zalika, do you want me to start? I would start with thank you very much for this question. It's very important for us. So Slovenia and Czechia are culturally very close countries. We have a lot of common in a history, and also in a history of health service, from Bismarck to the Semaško model and to the independent system with public health insurance. And we have, I think both countries has a stability of the primary care system that has been developed, as I said, for almost 50 years. We have the longer relationship GP-patient because GPs are important for patient in both countries. They have a lot of tasks in prevention, screening, etc. And I can talk for Czech Republic. So, for example, the self-confidence of GPs really increased in the last 10 years. There is a good public attitude to GPs and media picture. And I think we are on a good way to improve and get even more competitive. So this is answer from my side.
Yes, I would like to just add, maybe also one of the factors is that we have very good education in family medicine. Training is aligned with European standards, and also in both countries, academic family medicine is quite well developed. So I think this also can affect the good results measured in Paris.
Thank you very much for your response. I'm aware of the time. We still have 5 to 10 minutes. So if you don't feel necessary or if you don't want to read aloud your question, feel free to put it in the chat and I'll be happy to read it for you. I see Dania here in the room, and I know that she perhaps let me ask the question because it's not coming, so perhaps that may be useful. Did your countries rely on existing practice-based networks when implementing the studies? And if that was not the case, is that perhaps an approach that you think may help other countries in implementing similar approaches?
Yeah, so I will answer for Slovenia. Slovenia is a very small country, and we have a very good network of family physicians, which are grouped in our society of family medicine physicians. And we use different approaches to reach the physicians, but the most effective was person-to-person relationship, because we all know each other basically in Slovenia. So it was many times necessary to pick up the phone and call my colleagues and ask them to participate in the Paris study. What was in Slovenia also the best motivating thing for doctors to participate was the promise that they will get the results for their own patients, for their practice. And that has already been done. We already sent the practices, their results, and I got very positive feedback. So I guess this is one of the best things also done in Paris, because in other studies, participating doctors rarely get the results for their practice. They get the results of the whole study, but not for their practice. So that is from Slovenian.
We strictly adhered to the methodology and did a random sample of eligible GP practices. Also, we had like 1,000 practices chosen, and we addressed them by the special not emails, but the electronic way. And from those 1,110 positively responded. So that was what we succeeded. And these practices then collaborated with us, and they got some small premium of money, just motivational, but finally they were happy to participate, and they received feedback afterwards, as you know, from the patient assessment. So yes, so that was the Czech Republic.
So maybe just a small addition from me. We planned to do the random sampling, but then there is only 900 family physicians in Slovenia. So then we decided to send invitations to all family physicians in Slovenia, which proved better than draw the random sample.
Anna, feel free to add if there's anything that you think is relevant to the issue that we had discussed that you had proposed in relation to the practice-based research network.
Yeah, I was thinking that the pathway that Zalika described, it is exactly the same pathway that the networks have been developed in primary health care, the practice-based research networks, and also the fact that the information is precious for the GP. It is also found in our studies. It is common denominator for participation in research, yes. So I think that, let's say, this can be pathways to start and develop more stable infrastructures.
Okay, thank you. Just for the benefit, you may be wondering, I mean, Anna Dania is a member of the Working Party in Research, and she is leading an initiative about global practice-based research networks. I don't see any more questions. We still have 5 minutes. Viviana, I know that you had you had thought about issues related to doing similar research in non-OECD countries, perhaps. I guess that the idea is whether we can. Certainly the OECD provides an outstanding platform, and perhaps the problems may be in terms of the representatives for many populations who belong to lower and middle income countries who may find it difficult to be represented in such studies. I will ask perhaps Viviana if you want to elaborate on the question. And Jandan was here, is no longer. Okay, because I would have then asked Jandan to respond to this, but please elaborate on that, Viviana, if you think it's appropriate now. Okay, I'm trying to unmute. Can I unmute you?
Sorry, here. Yes, I wonder if, because one of the issues that I would love to see similar questions shared among non-OECD countries. I would love to see this distributed in Latin American countries. I would love to see this distributed in African countries, in South Asia. And it would be really great to see if, is this something that the Working Party on Research can help facilitate, the Ready BMEFA in Latin America? Could we work with PAHO? I do not know these are questions that perhaps the US chair, as a future chair of the Working Party on Research, can help us answer. Is it proprietary? I don't know if the questions can be, if it's okay to use the same questionnaire with other countries, but it would be wonderful. We're working with PAHO right now to do a survey of all of our member organizations, and perhaps our next step could be to connect the same efforts that we have been doing to develop or to share the same questionnaire among the countries of the Iberoamericana region, for example. And perhaps, I don't know if a consortium of primary care, the Afro-PHC, could go through in Africa as well. And so it will be I think it will be for all of us to start seeing, what can we do and what are the policy implications? Because I think often we want to see the research and what are the policy implications and policy briefs that can come out of this, especially for low-income countries.
I think that's yes, it's a very necessary way forward. What I will be talking in the next webinar about issues related to how the measurement system was developed. And I think one thing that is important is that so it was not necessarily designed to exclude any populations or any health systems, but it was designed to maximize the applicability to the countries that will be participating. And of course, it's very likely that we missed relevant aspects. So although technically it's in the public domain, it can be used. There may be benefits in considering how to supplement it, how to enhance the questionnaire. In addition, with the World Health Organization, my team at the University of Singapore, National University of Singapore, developed a survey for primary care for WHO and with a wider perspective. We actually piloted it in Ghana and Zambia, for instance. And it's already available in English, and any day must be out in the public domain too. I haven't checked recently, but it was supposed to be on the WHO website. So that will be an alternative. I'm fully aware of the time. I know it's midnight here, other times in other places, and I'm sure you must all go to do other stuff. I'm sorry that we were not able to allocate more time, but I hope you really, at least enjoyed it as much as I myself did. I'm sure that Zalika and Bohumil would be happy to share more information if you want to reach them. And you will also have another opportunity of discussing this thing at the next seminar. I may even want to, will try to keep it short so that we can perhaps discuss not just the instruments and so how things are measured, but also more broader aspects. So please let me thank very much Zalika and Bohumil for preparing the presentation, for making yourself available, and Viviana for finding time in your very busy schedule to join us, and for all of you for finding time also for joining us, for being with us, for asking questions and also contributing to the discussion. If I may ask you just for a split second, if you find it feasible to open up your camera so that we can just for a brief second see the people around, and that will allow us to capture this briefly for whenever people join us later. And if not, it's okay. Well, thank you very much, everybody. So I don't know how sound this is, but really a pleasure having you all around, and see you in our next webinar. Thanks.
Thank you.
Bye-bye.
Bye.
Bye. Thank you so
Bye-bye.
much.